Hello. It is time for my question and answer session tonight. So, got some questions that I've been asked in the week, which I'm going to go through. Just made a note of what they are. As ever, if you've got any questions, you can always post them live, and I'll be very happy to answer them for you. So, I have received a question via a direct message on Facebook from a patient who has sent me some photos. She's not a patient of mine. I don't know. I think she is someone else's patient, obviously, who had surgery. Not sure when, but she's had breast implants, and she's not happy with the result of the surgery, and has seen 3 surgeons and has had 3 opinions, and is asking for my opinion, which I have given. And I just thought it raised a couple of interesting points about revision following breast implants, because there are 2 issues that she has. One issue is that, probably less of an issue, but she says if she is going to have anything done to change the implants, she wants them to be bigger, which is a common thing that happens. And the other issue, the main issue that she's got, is that one implant is sitting lower, or one breast rather is sitting lower than the other breast, and that's something that she's unhappy with. And the interesting thing to me is she just sent the post-op photos, and it was evident that there was an asymmetry between the breasts. One nipple was lower than the other, and it's something that's very common to have an asymmetry between your breasts. In fact, I would go so far as to say it is normal to have an asymmetry between your breasts, because because everybody that I see pretty much has got an asymmetry between the breasts, and this is good, isn't it? Ooh, a bit warm. I can be props. Got some props. Everybody has got an asymmetry between the breasts, and the fact of the matter is that it's quite often that people don't notice it preoperatively, but they often notice it postoperatively. And so I make a point of pointing it out when there is an asymmetry between the breasts, or between the nipples, or between the volume between the breasts. Obviously, surgery, we're always trying to make things absolutely perfect and symmetrical, but to be honest with you, they never are. If you have an asymmetry of volume between your breasts, because the implants come like 220, 250, 270, 315, whatever, we'll often think about using a differential augmentation, but there has to be quite a significant asymmetry between the breasts to have a differential augmentation. A differential augmentation being different size implants in, because if you put a bigger implant in the smaller breast, that can often make that breast bigger. And so you have to decide whether you're going to make that breast bigger or just keep it smaller. And often you end up putting the same size implants in. So I'll say to people that you've got a bit of an asymmetry there. It's not drastic. It's quite normal. It's within normal limits. You'll still have an asymmetry afterwards, one way or the other. But the main problem this patient had was the breast height was asymmetrical. One was lower than the other, and the fact of the matter is that one nipple was a bit lower than the other, which was a pre-existing thing. You've got to think about what implants can achieve. Implants can't lift the nipple really, and so if you want to lift the nipple, then you need to do a lift. They can add projection. They can make the nipple stick out further, but they can't make one nipple. If there's an asymmetry of nipple height, you can't make one nipple go higher by using an implant, particularly if you're putting the same size implants in both breasts, because there wasn't a significant volume asymmetry, so it was just nipple height asymmetry. So what the surgeon had done was he had put the implants in to center them on the nipple, which is where they should be. So both breasts looked fine, the implants were sitting fine in both breasts, but one was lower than the other because one nipple was lower than the other because of a pre-existing problem. And what I said to her is, it would be possible to raise the fold on that one side to make the breast sit more level, but you wouldn't be raising the nipple. And so if you raise the implant and don't raise the nipple, and the nipple is then sitting on the lower border of the breast, it can make that nipple look like it's sitting lower than it is. You can make a nipple look like it's sitting low or high by changing the position of the implant. If the implant's too low, it can make the nipple look like it's too high. Similarly, if the implant's too high, it can make the nipple look like it's too low. So you got to be careful that you don't cure one problem and make that implant sit level with the other one, but create another one, because all of a sudden, hold on a minute, that breast doesn't look normal because the nipple's sitting at the lower pole of the breast, whereas it looks normal now. So that's interesting, and I think it's basically just to be aware of the asymmetries. And at the end of the day, you know, my view was, I think it was a good result of the surgery. The surgery was good. The asymmetry was in normal limits. I totally understand why people can be unhappy about these asymmetries, because they feel they've spent thousands of pounds on surgery and it should be right. But the fact of the matter is, we're often dealing with pre-existing asymmetries that it's not easy to correct. I mean, you can correct a nipple height asymmetry by making a scar around the nipple, but then you've got a scar on the front of the breast, and it's, to be honest with you, it's not worth it, because I would just say, look, you'd have to accept that was a pre-existing asymmetry and it's within normal limits. But I think the problem with all these things is having the counselling pre-operatively, because I think if she'd been told that pre-operatively, she'd have had it a lot easier to cope with it now. Or she could have made a decision. She might say, oh my God, that's going to be horrendous, I'm not going to have surgery, which is fine. Or that's okay, my breasts will be bigger and I'll be happy on those grounds. So it's all about preoperative counselling, which is why I always say to people, come back as often as you want, because we go over it. And, you know, I'd love going over it again and again and again, because every time you come, there's a little bit more information that you take in. It's hard to take everything in first time. So it's always good to have at least 2, and, you know, really as many as you want, consultations, because these nuances are really important to get hold of pre-operatively, so you don't feel shortchanged and cheated post-operatively when you have something that wasn't explained to you beforehand. It's the same with anything in life, isn't it? It's any sort of tradesman or anything. They do something and then something happens and they say, oh yeah, that always happens. If they told you pre-op, you know, before they did it, you could be a bit more forgiving. So the other point that she makes is about wanting to be bigger, and again, it's all about, not again, but it's all about width. And I felt that the width of those implants was good, which is the thing that I look for. I look for the width, because I'm thinking to myself, from my point of view, I'm thinking, if I'm going to put bigger implants in, they're going to be bigger in one of 2 ways. They're either going to be wider or they're going to be a higher projection. Now, in this case, I think they're already extra high profile, so I couldn't go in a higher projection. So I'd have had to go to wider implants, which would have been possible. But the problem with going wider, again, you can create other problems. Problems such as synmastia, web between the breast, uniboob. It's not a good look, difficult to treat. And it happens when the pockets merge, 2 breast pockets merge, if the implant's too wide, or they're too lateral and your arm hits them. So that can cause problems. If they weren't extra high profile, it would have been possible to go to a higher profile. But I say to patients, when they say, because lots of people come back and say, I wish I'd gone bigger, I say, look, you'd be different. You'd either be wider or they'd stick out more. And you may not like that look. You may like that look. It may be reasonable to go bigger and to change to higher profile implants, but you may not. So it's something to think about. And, you know, we go to great lengths to get the right implant first time. And though we do that, the majority of patients come back and say they wish they'd gone bigger, but that's okay, because the implants usually fit their frame. They're happy with the result, and in their mind they just think they'd like the same result but bigger. But they can't have the same result but bigger. They'd have a slightly different result. If they had bigger ones, they'd be either wider or higher profile. So that was good. So that was one interesting inquiry we've had this week. What I have also written here, revision, that's the one, pain 2 years. This is a patient of mine who's got pain 2 years after having implants, and I thought I'd just mention this because and I'm going to be seeing them in the clinic soon to talk about this, but I thought I'd mention it because it is interesting that you do sometimes see stuff like this. And it's difficult to know what to say to people before having surgery, because there are some things that happen with implants that are not common. And this is not common. And I'm going to have to look to check there's no other cause of the pain. because it's not common for for implants to be causing pain 2 years after surgery. I don't think it's just started. I think it's always had a bit of discomfort and it's never really settled. And this isn't usual, this isn't common, but stuff like this can happen, and you do see it occasionally. You may know that years ago silicone implants were banned in America because they said that they caused all sorts of problems, diseases, rheumatoid arthritis, SLE, all sorts of problems. And they looked for a link and they found no link, so they used them again. And the way I put it to people is that there's no link that implants cause long-term pain, but there are people out there who say they've got pain with implants in. Just because there's no link doesn't mean, just because we don't know a link, that there's a link, doesn't mean there isn't a link. So it's a tricky one. I've put it down here to talk about. I don't really know. We will do what we can and try and maybe get a pain specialist involved and see if there's anything we can help. Absolutely check there's no other cause, because that's something you don't want to be missing, a red herring, because people get breast pain without implants in. So we've got to make sure that there's not other cause of this breast pain, mastalgia. Obviously there are people who do get pain within the breast tissue. It's as I say, it's unusual for the implant to be causing the pain, but you do see it sometimes. And the first step is to exclude another cause. And then I think we would have to look at ways of alleviating the pain and improving symptoms, because let's say the implant itself to cause the pain is unusual, and it's difficult to know how to treat, because often one of the things that goes through people's minds if they have a lot of problems is, take the implants out. The problem is, because I can't categorically say the implant's causing the pain, I'll always have to say to them, I can't categorically say to you taking the implants out will make the pain better. And particularly in this case, this patient's very happy with the cosmetic outcome. So again, I don't want to cause another problem by removing the implants and trying to improve the pain. Hi, Arazu. But creating another problem, which is obviously the cosmetic issue of removing the implants without guaranteeing improving that. So I just thought I'd mention that. I don't know if that's helpful mentioning that, but anyway, it's just something that's happened this week. When wired bra fitted? No, I think actually that's just my notes here. I think when can you wear a bra and when can you get fitted? That was it, wasn't it? Breasty day today, isn't it? When can you wear a wide bra? This is after the patient having implants. The thing about having implants, certainly the way I do it, and I think most people in the UK, is using what's called an inframammary incision, which is an incision in the bra fold of the bra. I usually place it slightly a little bit off the fold, so slightly above the fold. But wearing a wired bra, the wire of the bra can sometimes irritate that scar. So I normally say wait about a month for the scar to settle. The scar will probably still be quite red and quite firm at a month, but it depends on how you are. A lot of people can't wait to get into a wired bra, particularly in the summertime. Not so bad in this weather, but in the summertime, those sports bras and the post-op bras can be quite unwieldy. So they can't wait to get into normal bras. So I normally say about a month, see how you go, and you can start wearing normal wired bras, see how you feel. So, it might be uncomfortable, the wire might irritate the scar, in which case stop. Don't just carry on because I said it. You can wear it at a month. Everyone's different, so try it at a month and see how you feel. And if it's okay, then it's okay. If it's not okay, then go back to your sports bra. If you want to carry on wearing a wired bra or the design of a wired bra, because they're often a bit more sort of strappy and less sort of wide on the straps, certainly if you're going out and things, you can remove the wire of a wired bra, but obviously that ruins the bra, so you may not want to do that. But if you did want to particularly go out for an event or wear a wired bra, but the wire is annoying you or annoying the scar, you can do that. That is an option. So with an option when to get fitted. Similarly, you have to wait for the shape and everything to settle. And I normally say that starts around 3 months. Now, obviously, you can get fitted before then. Well, not obviously, but if it was obvious, I suppose you wouldn't ask the question. But you can get fitted before then. And I don't think you're going to change your cup size. But the shape does take time to settle, and I know if you can wait till, at least don't go crazy before 3 months. You might want to get some bras in that time, but 3 months is really when things start to settle, and that's when I'd say, look, that's getting an idea what sort of size, shape you're going to be at 3 months. It's not going to totally settle 6, 12, 18 months, but things will start around 3 months. So 3 months is the answer to that question. So I hope that's been helpful. I hope you like the I'm in my casual today. Gone casual, and I don't know who put the lens or whatever over that side, because I've been looking over that side to start off. Am I looking at? Yeah, that's the lens, isn't it? So someone's looking at the wrong side, but there you go. That's what happens in showbiz. So that's me. I'm out. I'm gonna go. Oh, great, Dawn. Good. I've been getting excellent, Dawn. You got a question, right? Dawn's asking. I've been getting some sharp pains around the side. Is this normal? Right. Right. So I don't know how long post-op you are, Dawn, but you're quite a while, aren't you? I'm going to say couple of months. It's probably going to be more than that. It's probably going to be 4 months or something. Anyway, totally normal. Particularly any time you do any surgery, you're messing about with things, and you're messing about with this sort of sharp pain thing is nerves. Basically, it's nerves, little nerves. You're cutting through any nerves. I had a hernia repair, and literally, I thought you said just had it done. June had it done. Blimey, O'Reilly, you are kidding me. What's that? 5 months or something? Wow, where'd that go? Where'd this year go? Yeah, even after a year, I was getting some funny pains in my hernia repair, and that's just the skin. There's little nerves, tiny little nerves, not big nerves that actually supply important stuff, but there's tiny little nerves in the skin all over the place, particularly things like a breast reduction, because you're moving everything all over the place. You're moving things around, you're moving tissue around, and you have to reshape the breast. And so anytime you're cutting through tissues and moving things around, there are little nerve fibers, they're like little electrical cables, and they're just firing off, and sometimes you get funny feelings, sometimes you get pain, sometimes it manifests as these sharp pains, hyperesthesia, which is overly sensitive area, particularly sensitive places like the nipple. The nipple's a very sensitive area, so you can get discomfort around the nipple. Sometimes you get numbness. It's unpredictable what sort of things can happen, but it's not unusual. There you go. It's not unusual to get problems like this, and it can take a while. It can take. I'm saying about a year. All right, Andy, hold on. I've got to. That question's going to go in a minute, so I've got to read. I hope another question doesn't come in, Andy, because I'm going to miss your question. It can take a year or so for that to... I wonder if I can scroll these questions. Oh, yes, I can. It can take a year or so for those numbnessy type problems and sharp pains. And Dawn, you're within a year, you're in June, so you're absolutely fine on that. Massage, especially the sharp pains, massaging it in the hypersensitivity, massage can help to desensitize those areas. And basically don't worry about it. It's the nerves. Nerves take ages to recover. As I say, it's not major nerves. It's not like nerves that are supplying important structures. It's just little cutaneous nerves that supply the skin that fire off and cause you all sorts of problems. So that's totally normal, Dawn, and I hope it doesn't bother you too much. But let's face it, you've had a big op, and it takes a while for everything to, your brain to reprogram itself that everything's in different places. So it's totally normal, and you're going to be fine. And I hope it's not too troublesome. But massage is my advice for that one. And you're doing the massage, excellent. Yeah, well, that keep up the good work, and that's and supportive bras and things like that. That's also helpful. So what we got here is we've got a question which says, Andy Baker, I have more or less double bubble on my left where my crease was moved. I had surgery in April. My surgeon said he can't do anything. I was meant to have a nipple lift, not a lower crease. Right. Okay. Well, you mentioned I don't recognise your name, Andy, so it's not me. I'm off the hook. I haven't done it. I haven't done this. That's good. Double bubble. Yeah. I know what you're saying, Andy. I know what you're saying. This is a problem. So what's happened here, what we're talking here is basically this is the thing, you know. I think people worry about what implant to choose. They worry, they spend ages, sleepless nights. You'll have 360, 390, you'll have high or medium, this and that. And I'm not saying it's not important what implant to choose, but it's so important to put the implant and get the implant in the right place. Because if the implant's not in the right place, it doesn't look good. And this is a problem, Andy. And I know what you're saying here. So what's happened here is that what the surgeons had, well, basically, if the breast is sitting a bit low, you either lift the breast up to meet the implant, or you bring the implant down to sit with the low breast. And often that means lowering the inframammary fold, because if you put the implant in where the current inframammary fold is, the fold where your wiry bra sits, and your nipple's sitting low, you have an implant up here, a nipple sitting down, breast sitting down here, it doesn't look good at all. So you have to lower the inframammary fold. Now this is what's happened here. You can see the original inframammary fold, and you get this double bubble or this problem where the lower pole is a problem, and it's difficult. I'm not sure about this. I was meant to have a nipple lift, not a lowered crease. That sort of suggests you went into surgery thinking you're going to have one up and got another one, which is a little bit alarming, because the best way to make the shape of a breast better, I always say this, best way to make the shape better is with a lift. A lift, if the shape wasn't right before, a lift is the best way to fix that. But there are scarring and complications with a lift, don't get me wrong, it's a big deal to have a lift. So a lot of people don't want to go down that road, and there are things you can do with implants to try and make the shape better, this being one of them, lowering the fold and trying to make the implant sit with the breast. As I say, you're never going to lift the nipple, but you can make the implant sit with the breast. But it is a very difficult problem, Andy, and there are things you can try and do. You can try and score that inframammary fold to try and release it. The other thing I'd ask you, Andy, is how long post-op you are, because you've got to give time for the breast to expand that lower pole. The implant to expand that lower pole. Often you get a ghost of where that fold was in the early stages, and it can take a while for that to stretch out and for those implants to settle. They often start a bit high, lower pole doesn't look quite right, upper pole looks too full. Some people like the fullness in the upper pole, but in time that upper pole fullness settles, the lower pole rounds out. So I've got to say, if you're within 6 months, even if you're within a year, I would say, look, try and see if things are going to improve on their own. Try and avoid further surgery if you can. A nipple lift would do the trick. That was one thing you could do. You could lift the breast back up onto the implant, but it is tough to get to remove the memory of where that old inframammary fold is. It's a difficult problem you got there, and it's tough if your surgeon's saying they can't do anything, and particularly if they were supposed to do a different operation. That doesn't sound good. But the most cosmetically sensitive area is the upper pole. So often the upper pole looks good, and you probably look good in clothes. The problem is out of clothes, it doesn't look good, and it's a problem. My advice is leave it as long as you can. Things might settle. If they don't, then maybe get another opinion and see if there's anything that can be done, like things like scoring, to try and help release that lower pole, to help forget that memory of where the old inframammary fold was. Similarly, a lift to bring the breast back up, fat grafting into the area, because it's, things like that. Not great actually, fat grafting into that area. It's difficult to get the fat graft into that old inframammary fold, but it's a tough problem, Andy. You have pointed out a very difficult problem to fix, and I haven't got any easy answers for you, but it is, one of the things that I do say to people preoperatively. It's so important to try and get those implants sitting right, whereas people will worry about the implants that they have, but they should worry about getting the implants sitting right, because if it doesn't sit right, it doesn't matter what implant you've got. If you've got an inframammary fold that's still in place, double bubble, and as I said before, uniboob, symastia, all these problems, they can be really hard to fix, basically really hard to fix. But probably the best bet is a nipple, not a nipple lift, a breast lift is probably your best bet, but it's difficult. If you can send me some photos if you want, direct message. So that's what sometimes people do, and I'll have a look. If you want me to have a cast an eye and give me some ideas about how long post-op you are and things, I can try and help by a Facebook consultation if you would like. So yeah, that's excellent. We've got a couple of oh god, have we got hold on a minute, what's going on here? We've got more questions. The implant, oh, sorry. The implant was supposed to push my old crease out, yes. April, oh God, right, okay, I'm way behind on the comments. April, so yeah, you're within a year. Thank you. I may see you in the future. I do what you rate. Oh, that's kind. He's brilliant, Andy. Definitely go and see him if you ain't happy. Oh, that's kind. Thanks, Dawn. Yes, so yeah. April, it's quite a long time, April, isn't it? Because it's getting on for a year. I'm hoping things are maybe things improving a bit. I normally, you wait as long as you can, number one. But number two, the other thing you've got to be mindful of is the revision policy of the hospital. Some hospitals have like a year revision policy. So you don't want to see them in May next year and they say, yeah, okay, we'll do another operation. Oh God, you're out of the revision policy, you have to pay. So that's the other thing that you've got to be, have a thing sort of hanging over your head as a surgeon. Sometimes I'd rather they just had, 5 years on it, to be honest, because the longer you leave it, the better. But if they've got it, they might have a time limit on their revision policy. So that's something I would be a bit aware of. But the policy from a surgical point of view is the longer you can leave it, the better. And it is a difficult problem to correct, Andy. I haven't got any easy answers for you, so I'm sorry about that. So that was a good one, wasn't it? A good bit of interaction there. Thank you all. Everything costs money from here in. Okay. No revision policy then. Okay. Well, then there's no time limit. So I suppose on the bright side, there's no time limit. I took that as there was no revision policy. Yeah, I would take it as that as well. Right. Okay. Well, that's a shame. But as I say, it's different. There's no obvious revision surgery to be done at the moment. I think that give it some time and be positive, and hopefully in time that implant will stretch the lower pole and stretch that old inframammary fold out. But I'm sorry you got that problem. But hopefully, let's be hopeful that get next few months, that'll maybe things will start to soften and settle and improve. Fingers crossed. Hope things get better. Good. Okay, so that's great. Well, it's nice to have you on board, Andy, and everyone else. Thank you for your questions, and that was a good one. So I better. It's a relaxing day. I'm in my casuals, and I'm going to go and relax some more now. I'm going to put my feet up and watch a bit of telly or something. Okay. I'll probably get to the telly actually, but kids on it and all that. But anyway. Thanks for listening, and I'm going to go away now, and I will be here same time, same place, 7 o'clock next week. Any questions, Facebook me or send them to Laura. Laura, I had things to say, I had announcements. I should have said them at the beginning. Well, anyway, Laura's leaving, so you can still send them to Laura. We're going to merge the email address. It's going to be Emma. They're having a week of crossover, so very sad to see Laura go. Laura's going to do a degree. She's starting next year, so Laura's going. And the other thing I wanted to say, which I'll say at the beginning, but I'll forget, is I've got a podcast. There is a sternoplastic surgery podcast. You heard it right. We have made Facebook Live sessions into podcasts and also into YouTube. There's a YouTube channel. If you haven't subscribed, why not? I need 100 subscribers. If I get 100 subscribers, Friday she finishes, Dawn. I need 100 subscribers on Facebook, and then I can get a bespoke name at the top, and I need 10,000 views, and then I can start putting links to my websites on the pages. And I've got 43 subscribers and about 2,500 views, and that, I've got to be honest, is a little bit depressing, because my children watch balloon battles, and that one video will have 2 million views of someone playing balloon battles or something. So don't ask me why I can't get 10,000 views out of all my hundreds of videos I've got on there. But I'm not bitter, good luck to the balloon battles guy. I don't know if I do a balloon battles video, will I get some views? Almost certainly not. But anyway, so there's a Facebook Live video of these. We're archiving them all on Facebook Live. So please do join and subscribe. And I'm also doing regular videos on Facebook Live, not on Facebook Live, on YouTube every week now. We're doing a new video every week on YouTube. I'm officially a YouTuber, and I'm also officially a podcaster, because we've turned all these into podcasts. So the media is just, unbelievable. So yeah, please do those things. Subscribe to the YouTube and do whatever you do to podcasts. I don't even know what you do to those. Subscribe to those or whatever, or listen to them, because it's on iTunes, podcast on iTunes. Sternoplastic Surgery Podcast, it's called. So yeah, I should start advertising those, shouldn't I? Anyway, I've gone on enough. I'm going to check out of here, and thank you all for your participation, and I will see you next week, and I hope you have a lovely rest of the evening. Bye.